Good morning, everyone. This is a symposium entitled Invasive Fungal Infections in HCT Recipients. We will do this based on two cases that will be presented. My name is John Wingard from the University of Florida, and joining me is Kieran Marr from Johns Hopkins.
The following audio is based on a recent live symposium with Dr. John Wingard and Dr. Kieran Marr. This audio is part of a certified educational activity titled Invasive Fungal Infections in HCT Recipients, Case-Based Perspectives on Prevention and Treatment. To access the entire activity and complete the post-test, please go online to www.peerreviewpress.com/GKU. A printable transcript, slides, practice aids, and other features are also available.
So I'm going to use this case. It's a real patient because it's a good case that just outlines the types of decisions that we need to make when developing algorithms to prevent infections. This is a 63-year-old lady with JAK2 positive polycythemia vera myelofibrosis that progressed to myelodysplastic syndrome, and she's now day 4+ status post and non-ablative haplo transplant from her daughter. She's got no localizing complaints or abnormalities on exam, but she has a high fever of 38.6 and her ANC is 90. This is her regimen. Her current medications are standard prophylactic drugs at Hopkins, and I think that this is a very common scenario. It's one that I'm just putting up here to outline critical questions that I'm going to be talking about in this talk. How do we assess individual risks for invasive fungal infections? Is fluconazole enough for the early post-allogeneic transplant period? Should we use a mold activazole on everyone? The related question, how should we monitor patients for invasive fungal infections? And I'm going to start with something that we actually really know, and that is that prevention of infections is really a key driver to better outcomes. And I can think of no better study to demonstrate this than the one that Ted Gooley led and published in the New England Journal of Medicine in 2010, and that is the Hutch Experience. This was about 1,400 patients over 2 cohorts in time, and the goal was to evaluate the significance and improvements in supportive care regimens, of which one factor were significant infectious complications. And the primary finding was an improved probability of survival here in the latter time period with an associated less incidence of invasive infections, specifically CMV disease, gram-negative rod infections, and fungal infections, both in that study being Candida as well as Aspergillosis. And so that really was a very important finding. Of course, many things going into it, but the important thing was that it was censored for relapse disease. How do we prevent invasive fungal infections? We can use prophylaxis with drug up front, treat fever during neutropenia or when the patient jumps and risks, or use some kind of preemptive test, such as what we do standardly with CMV disease. I think that what has been evaluated most robustly is, of course, is fluconazole prophylaxis. This is about 20 years worth of work, several randomized trials, one of which is shown here. This is the one that was done in Seattle that showed 300 patients compared to placebo. Fluconazole was associated with a decrease in overall mortality, decrease in infection-related mortality, and that probability of survival had a long-term effect in people that received fluconazole, likely due to multiple reasons, not just preventing invasive fungal infections, but other secondary effects, as it turns out. But we've since done several randomized trials to evaluate which azoles are better. Of course, going from candidiasis with an emphasis then to preventing invasive mold infections. These focused on itraconazole, posaconazole, and voriconazole. And I'm going to go through the latter studies here to illustrate some relevant points. This is the result of the posaconazole trial that was done and published back-to-back in the New England Journal of Medicine with an AML study. This is the graft versus host disease triggered posaconazole versus fluconazole study. And in this study, the probability of invasive fungal infection was lower in the posaconazole group. That was the primary endpoint, and though there was no difference in overall survival, that was really a very compelling finding. Of course, this was with triggering the drug after the onset of graft versus host disease. Now we have solid oral tablet that has better absorption levels. It's not been studied in that type of environment, but the pharmacokinetics are much improved. There is as well the BMT-CTN study led by John, and this was a trial that we designed to evaluate voriconazole versus fluconazole up front at the onset of receipt of stem cells. We designed this trial very, very differently than the other trials that have been done. I think this is a very important point, and one that people don't really understand in enough depth. The hypothesis is that we could decrease fungal-free survival, and so that's a composite endpoint that we put together in order to minimize the likelihood of informative censoring caused by potentially increased toxicities in the voriconazole arm. However, we measured that at 6 months, and so that was a very robust and late-term primary endpoint. Two other important things is that we selected moderate risk allogeneic stem cell transplant patients, and we used concomitant screening with the Galactomannan assay. And in that context, not just the head-to-head drugs, there was no difference in the cumulative incidence of invasive fungal infections, and there was really no difference in fungal-free survival. At least it didn't meet the primary objective, although you can see that these curves did separate somewhat in the beginning. If you want to look at those studies kind of head-to-head, the Ullman trial and the Wingard trial, I see it on this kind of a graph where we're measuring the significance of separation between the total infections that were demonstrated, and you can see that there were the same kind of trends for posaconazole and voriconazole. In fact, an almost exact similar risk reduction of 0.04, although the p-values were different. It becomes very hard to compare the results of those studies or come away with a conclusion as to what is better. There's another study that has been published, the itraconazole versus voriconazole trial called the Improve-It study, and this showed the primary composite endpoint, higher success with voriconazole compared to itraconazole, but no difference in overall survival, although some interesting trends during the late time point. So take-home point number one, prophylaxis works, both to prevent Candida as well as aspergillosis. Azoles are a staple drug here. Two mold-active drugs have unique advantages and limitations, that being posaconazole and voriconazole. The variability in those study designs really preclude any demonstration or comparison of which one is better. And I think the risk versus benefits are individual assessments based on understanding who really is at high risk for a mold infection. And this is where it becomes really very complex. Risks for mold infections are a perfect storm, if you will, with a number of different host-driven risks as well as exposure-driven risks, many of which we never really anticipated until we started looking at them in depth. And you can see a lot of them emphasized here. I'm going to focus on two, one being weather and geography and exposure, outside risks, and another one being your genes. The best example, I think, of how weather and geography impacts the onset and risk of invasive aspergillosis is what we uncovered in Seattle using a database of 4,000 people between 1992 and 2003. And this is a very comprehensive Aspergillus database that we created. The cumulative incidence of aspergillosis was higher, much higher, in the warm weather periods seen in orange and red, both in the early time periods as well as in the latter time periods compared to the cold weather months. And this is something that anecdotally we suspected just because of the amounts of cases that we were seeing during that time period. So we hypothesized that this was related to weather and then recruited another site, MD Anderson, to do a comparison of the same kinds of weather patterns that may actually be impacting ambient spore counts. And we found that, and this was obtained from the National Weather Service at both sites, we found that indeed you see an increased probability of aspergillosis during the summer in Seattle, but flat in Houston. And this was associated with an increase in spore counts during those warm months that was flat in Houston, even during the warm months. And we think that it's because of precipitation, because when it gets hot in Houston, it also gets wet. When it gets hot in Seattle, it gets very dry. And that's an environment in which these spores that are very hydrophobic can actually be dispersed. And we're breathing more and more of them. And so you can see how both geography and weather patterns can impact the daily exposure to these ubiquitous organisms in the environment. What's another important risk or important factors that we're now just really understanding is the impact of our genes, especially the variation in innate immunity. And if you take, for example, the human toll-like receptor signaling pathway, of course, there's monogenetic disorders that have a very high penetrance, and they become apparent early in life as having severe immunodeficiencies, especially ones that are related to signaling, to centers of the signaling pathways. But much more commonly are polymorphisms in multiple genes in which we all just have variability, and they don't become apparent until you strip off multiple layers of innate immunity. If you consider the complex innate immune response to fungi, there could be many different polymorphisms on genes that are conferring frontline defense to these organisms, specifically associated with inflammatory responses to the carbohydrate-ridden cell walls. And this is particularly true for toll-like receptors, dectin-1, the beta-glucan receptors, or DC-SINE. It's been shown nicely for toll-like receptor 4. This is a study that was done in 2008 by Pierre-Yves Bouchud that's analyzed by mass spec using that same Aspergillosis database. That's the polymorphism in toll-like receptor 4, especially combined with CMV positivity in the donor, was very much associated with risks for invasive aspergillosis. Importantly, we don't really understand the functional effect of that polymorphism. But there's other ones that we don't really know, we hadn't really suspected straight off. One of them became apparent in 2014, was a polymorphism in pentraxin 3, which is a soluble pattern recognition receptor. And in this study, again published by the Italian group in the New England Journal, you could see multiple polymorphisms in the host pentraxin 3 genes are associated with the probability of aspergillosis, as well as impacting the overall survival after match-related stem cell transplant. So it's quite complex indeed, and there's probably many others. We have shown at least dectin-1 being associated as well. I would submit that there's probably a lot. So take-home point 2, beware of everything that we don't know and we can't measure right off the bat. There's probably a lot of genetic risks in both the donor and the recipient that are conferring overall likelihood of invasive disease to these ubiquitous organisms. The real compelling question is there a way to screen and implement a strategy based on those data? And that is not really known yet. And can this explain risks for recurrent infections over time? Now let's talk about recurrent infections and pause for a moment and appreciate that when we look at these risks and cumulative incidence curves, what we're looking at largely are analyses that are dependent on time to first infection. And in fact, there's a lot of people who have recurrent infections, and we don't know what characterizes them, and that may be actually a more important variable to be measuring. Because when you look at time to first infection and those time to event analyses, you can see a lot of misleading possibilities in your analyses and even in randomized trials. One is, for instance, in the prophylactic setting, a prophylaxis reduces the risk of your initial infection, but it's not effective at lowering risk for subsequent infections, and that's a little bit troubling. Another is the prophylaxis can reduce the risk of one infection, but lead to higher risks for others. And that would be, for instance, a very good example of what happens when we give people, for instance, a ganciclovir-related prophylaxis strategy that can induce cytopenias, that can prevent risks. And that's more troubling. But the most troubling would be if that prophylaxis strategy actually produces death. And this is obviously a problem, and it's not easily observed. It's not easily pieced apart in randomized trials that use that incidence of invasive infection as a primary endpoint. So how can we adjust what we're doing here? Well, we need to appreciate outcomes over a course of a long period of time. And this is something that I've started to really work on in more depth since I moved to Baltimore. We started a cohort study in 2012 of patients who had received both solid organ transplant and stem cell transplant at Johns Hopkins. And here's data that came out of the haplo transplant. This is actually a non-ablative haplo cohort over this period of time. We used active consent and patient engagement every 3 months and standardized definitions. And it enables you to actually do some really important and I think very compelling types of longitudinal analyses, whereby each line here, for instance, represents one patient. And if you consider that, there are people here that really did very well without any development of infections. These are the types of infections in that study. And there are people that had many different infections here. And then there are people that died early in infections right before death. And those latter two types of patients are the ones that we need to be able to identify in much more granularity in order to really develop these preventative strategies. So take-home point number 3, these time-to-event analyses may be hazardous in drawing conclusions regarding preventative treatments. And I think that these event-driven cohort studies may indeed be very useful, coupled with recurrent event analyses, because they evaluate outcomes over a longer period of risk. I want to transition here to the concept of preemptive therapy with a little bit of discussion over what the tools we have for diagnostics. The first one, and the one that we're all familiar with, is the Galactomannan enzyme immunoassay. I think it's really important to understand what we're dealing with here. This is Galactomannan itself. This has a mannan backbone with side chains of galactofuranose. And this is a moiety, a carbohydrate polysaccharide moiety that is present on hyphae and cell walls of many different fungi, especially ones in the Ascomycetes class. And so when you read something that says that this is an assay specific to Aspergillosis, it is not specific to Aspergillus. It's just that that organism is the most common pathogen within the Ascomycetes. The other thing to think about is that the antibody that actually that targets this actually recognizes galactofuranose, not the entire molecule. And so that means that there's other galactofuranose containing moieties in other products, not just fungi, that can cause some false positivity. And indeed, that's true in a lot of different foods, for instance. A lot of different clinical trials now, though, have used that assay as well as others, for instance, PCR, to see whether or not we can impact change with regards to use of antifungal therapy or invasive disease. This is one study, large study that was done in Australia, where allogeneic stem cell transplant patients were enrolled to a biomarker approach or a standard treatment approach. And what they essentially showed was you can see a decrease in antifungal use when you use the biomarkers. And it suggests this type of strategy may be very effective in managing these patients. You take a cohort of patients at high risk and you separate them to patients who are not on prophylaxis. The biomarker-based diagnostic strategy probably works. In people who are getting more prophylaxis, the same thing, but if you're giving a mold-active drug, this could be used as a targeted diagnostic strategy. And John's going to go into how those drugs, in fact, do impact the performance of our assays as well. One of the concepts, though, that I want to emphasize is the importance of understanding the significance of a negative finding. And this is something that is very, very difficult, I think, for most clinicians, and is becoming more and more highlighted as the sensitivity of our assay or the performance of our assays coupled with each other is enhanced. This is a meta-analysis that was published last year in 2015 that evaluated the studies that used Galactomannan and PCR and then separated them into no positive tests. In that setting, Aspergillosis is highly unlikely. One positive test, it cannot be confirmed or excluded, and at least 2 positive tests, diagnosis is likely. And in fact, this setting confers a 100% negative predictive value. And this, again, is probably in people who are not receiving a mold-active drug. This 100% negative predictive value, I think, actually is a very, very important observation that we should think about a little bit more as our assays are becoming more and more sensitive. And one of the assays that is really incredibly sensitive, that may be a game changer if it can be evaluated as a serial type of screening assay, is the one that's shown here that detects fungal beta-1,3 glucan. And I want to go into a little bit of depth on how this works because it actually can teach us a lesson that you're not going to forget. This is, for all of us who have worked in a laboratory, we used a standard called the Limulus amoebocyte lysate assay to detect endotoxin. Remember those assays, the chemical assays that you checked all your media with? That's an LAL assay that uses reagents from a horseshoe crab in order to find endotoxin. This is the other arm of that assay, whereas these reagents in factor C detect endotoxin, or LPS, from bacteria. These reagents, factor G, detect 1,3 beta-glucan. And there's a number of different assays using different outputs. Now, why is this important? Let's think about where it comes from. It actually comes from horseshoe crabs. Horseshoe crabs are big crabs that exist in the ocean, and they don't have an immune system. They have a very primitive chemical-related immune system, whereby if they get bacteria in their shell, these settings, these factors become activate, and then they just coagulate that place where that bacteria is. If they have fungus underneath their shell, they activate these chemicals, and that becomes coagulated. So in a very primitive creature in which they have these chemicals as their primary innate defense, do you think that you would want it to be a very sensitive or a very specific test? Really sensitive, right? It's very easy to detect LPS, endotoxin, or beta-glucan. And in fact, what you probably don't know is that the way that we produce this assay is by finding or getting those chemicals straight from the blood of horseshoe crabs. They have blue blood. And what's going on is off the coast of Japan and off the coast of New England, they have farms where they collect these horseshoe crabs and bleed them. This is a real picture of draining the blue blood from the horseshoe crabs. And from this blue blood, they harvest factor G and factor C for these beta-glucan tests or endotoxin assays. And then they take those crabs that are still alive and they throw them back in the ocean and then pick them up again. So I'm showing this as a visual because I think, number one, it's really interesting how these tests are done. But number two, I don't think that you're going to ever forget that this is an assay that is highly sensitive but not specific at all, because it comes straight from the immune system of a horseshoe crab. So if you have a negative beta-glucan in a setting where you think that you may have a Candida infection or an Aspergillus, it's very sensitive there too, although we don't know, or pneumocystis, it's really unlikely to be true. And the problem is we're kind of Bayesian thinkers, and we don't know what to do with negative conclusions. Because if we thought that it was a fungal infection before, a negative test just doesn't really get it for us to accept that that infection is there. And a positive test is really more helpful because having an explanation for that syndrome allows you to create a strategy to make an effect, even if it's a positive effect that is for something else. And so I raise that question, is preemptive therapy really an option? Or is sparing antifungal therapy really an option using these tests? I think it's gonna take some really good structured randomized trials to convince all of us Bayesian thinkers to really consider a negative finding as being negative. So I'll conclude here. Epidemiologic advancements enable development of effective prevention strategies, and we have a lot of them. We're doing more to understand how best to use those drugs, but right now we can prevent candidiasis and aspergillosis with azoles. I think that we're needing to push forward a little bit more and moving towards a personalized approach. That may be patient-specific clinical risks, genetic risks, or outcomes over risk periods. And there are many diagnostic developments that will allow us to implement them in preemptive strategies if we believe their findings. Thanks for your attention.
Thank you, Karen. I don't think many of us will be eating crabs for dinner tonight, I suspect. So I'll begin with the case. This is a 43-year-old man with acute lymphoblastic leukemia who undergoes allogeneic transplant using an ablative regimen. He engrafts and develops graft versus host disease, which is treated with corticosteroids, and on day 36 develops a fever, cough, scant sputum. On examination, you notice some scattered rows in the right chest. Being an astute clinician, you suspect pneumonia. Various retrospective studies suggest that the rates of pneumonia after transplant are in the 25 to 35% range. Now, so your first question is, what is the best image to evaluate this suspected pneumonia? And there are attributes in favor of a chest radiograph. It's quick, it's easy to do, and very inexpensive. But I would submit that perhaps you might better select a high-resolution CT scan. The sensitivity is very high. It has a high negative predictive value. And you can detect infiltrates much earlier than a plain radiograph, on average about 5 days earlier. And studies have shown that a CT scan, in contrast to a radiograph, often leads to a change in the clinical management. And the details of what that infiltrate looks like that you can't discern in a plain radiograph can help you with the differential diagnosis. So you choose to do a CT scan, and this is what you find. In one lung, you notice a dense nodule surrounded by an attenuated halo-like appearance, and in the other lung, a much smaller but dense rounded nodule. So you then ponder what is the differential, and I would submit to you that the etiology is influenced by several factors. First is the radiographic pattern, and they can be broadly categorized into either diffuse or nodular. Clearly, in this case, it's in the nodular category. And the timing, early after transplant or much later, very different differential set of diagnoses, and this is relatively early after the transplant, and the relative state of immunosuppression. So if this was a screening CT prior to the transplant, the patient would be relatively less immunocompromised than in this case, early after transplant, graft versus host disease, corticosteroids. And you can broadly divide etiologies into those that are non-infectious from those that are infectious and not highly immunosuppressed or highly immunosuppressed. For the not highly immunosuppressed, this is well worked out in the non-immunocompromised patients, but I think it's a broad perspective that is very similar to our situation when we are evaluating asymptomatic, not highly immunosuppressed patients, where roughly neoplastic diseases or infectious granulometer are the general causes of those. But in our situation, a highly immunosuppressed patient, we're broadly thinking about infectious etiologies, most principally bacterial and invasive mold infections, or mixtures of both bacteria and fungal infections together. So are there details about this infiltrate that could help one discern a bacterial from a fungal pneumonia? And when we talk about molds in terms of causes of pneumonia, 90% we're talking about Aspergillus, 5 to 10% mucor, and the remainder few percent are every other fungal pathogen you can think of. And there are certain features in the infiltrate that would favor mold as the etiology. The presence of a macronodule, the presence of a halo, as in this patient, or the presence of a cavity or air crescent sign, all would favor this to be more likely to be a mold etiology. If it's an airspace consolidation, that would favor bacterial etiology. And if you have small central lobular nodules or ground glass opacities, they can occur in both types of etiologies. And thus you can get some sense of what the likely etiology, but I would caution you that none of these are discrete, and you can have different kinds of types of infiltrates with both types of etiologies, and thus none of this is diagnostic, and I would encourage you to further pursue the diagnosis. Now, there is one radiographic feature that is helpful, in my opinion, to distinguish the likelihood of mucor from Aspergillus, and that is a study done by Dimitri Konianis at the MD Anderson, where they looked at the infiltrates attributable to mucormycosis or Aspergillus, and noticed that very few of the Aspergillus infections had involvement of the sinuses or the combination of sinopulmonary or rhino-orbital-cerebral findings, in contrast to mucor, where nearly half had those. And so in our institution, we typically will also do sinus CT scans at the time we do pulmonary CT scans. And when we find pulmonary, we then take those patients to endoscopy of the nasal passages and initiate therapy directed towards mucor. And in the absence, in our center, mucor is uncommon, and thus we will focus our attention on Aspergillus. Now, Karen has already mentioned to you about the Galactomannan and glucan strategies to screen patients. But I would also point out one additional thing is that these are positive very early in the course of infection, and several studies suggest that they are frequently positive even before the onset of overt clinical syndromes. And thus they can be very useful in guiding you to a further diagnostic assessment. One cautionary note, if you choose a mold-active antifungal approach, and many of you do from your survey in the poll, that the use of those mold-active agents can reduce the sensitivity of these assays. And this is a study from Karen's center, and she noticed very clearly that the sensitivity was dramatically reduced. In other words, in a patient with a suspected syndrome, there were fungal infections when the assay was negative under the influence of the mold-active therapy. Again, pointing you to diagnostic assessment. Now, in addition to Karen's comment, I would point out that this can be a diagnostic used in evaluation of pulmonary infiltrates, such as our patients, because while we can detect galactomannan in the blood, we can also detect it in respiratory secretions. And indeed, there are some data that suggest that the sensitivity in bronchoalveolar lavage samples can actually be even higher than in the serum, very high specificity, and very acceptable positive and negative predictive value. And thus, galactomannan detection in CT-based BAL fluid has a very high predictive value for early aspergillosis. And indeed, these are two series, one from Europe, one from our center, where you can see that when we employ this as part of the test that we do for our BAL testing, that a lot of the infiltrates that were possible in the EORTC-MSG diagnostic criteria, because they lacked the specific radiographic criteria, they were actually upgraded to probable or proven Aspergillus. And in the Martin series, this increased from 30 to 45%. And in our center, it increased from 22 to 54%. I would point out to you that this is a very important test that I think that really negates the need for doing transbronchial biopsies because they impose a greater risk to our patient of bleeding or pneumothorax. And the incremental yield from the transbronchial biopsies is very marginal, with most series giving it only about a 5 to 10% increase yield. So we have found this to be very useful in the diagnostic assessment. And I would just add one more comment. Another test that can be useful is PCR assays for Aspergillus. This has mostly been studied in Europe, very sparsely studied in the United States. And these assays are widely available in Europe. And you can see that the sensitivity and specificity in the various studies and meta-analysis is actually very good and approaches that of Galactomannan and glucan. And the combination of both the Galactomannan, in addition to the PCR screen, may be actually better than Galactomannan alone, as was shown in a very nice Australian study recently. But the caveats are that for those of us in the United States, there is no commercial assays. There are multiple technical challenges that influence the performance of the assay. Many of these have now been identified for standardized procedures, and that has certainly improved the performance of those assays. But we think that this actually, the state of what we know about these and the performance characteristics is enough that in the EORTC MSG guidelines that are being revised, that it's likely that the group will decide that there is sufficient evidence to accept this as a criterion alongside of Galactomannan and beta-glucan. So there are several important principles of the treatment of invasive aspergillosis. As this case, we thought that from the clinical and radiographic criteria, and also the patient did have a positive Galactomannan, that we thought that this was aspergillosis. And these have been codified by the IDSA. These guidelines are now under revision but have not been finalized. And one important facet is to start antifungal therapy promptly. I'll show you some data. There are 3 classes of antifungals now that are very active: mold-active azoles, polyenes, and echinocandins. I have listed them in the priority order of preference according to the IDSA guidelines. I'll show you some data. And if possible, to reduce immunosuppression or to restore the immunity if possible. And in certain situations, surgical resection of necrotic tissue would be advisable. This has not been well systematically studied, and it has to be individualized according to the patient. So I have suggested a diagnostic algorithm. So if you have a patient with respiratory symptoms, get a high-resolution CT scan, not a chest radiographic. And then you can divide this into either a nodular infiltrate or diffuse infiltrates. Both need diagnostic assessment, and in my view, with a bronchoscopy and BAL. The diffuse infiltrates, very early after transplant, are mostly non-infectious. Fluid overload, hemorrhagic alveolitis, toxicities from the conditioning regimen, a variety of things, and early after engraftment through virus etiologies, pneumocystis, and a variety of other etiologies, very different than that of the nodular infiltrates, which are principally bacterial or fungal etiologies. No matter what type of infiltrate, I advise the performance of a bronchoscopy. With the nodular infiltrates in particular, we recommend coupling that with the BAL Galactomannan to improve your yield. But while you're doing the diagnostic assessment, start antifungal therapy presumptively with the suspicion of a mold etiology, even before you make the diagnosis. This is crucial. What I advise my colleagues and my fellows and residents is do the CT scan on Thursday and look at it before 5 p.m. so that you can call the pulmonologist, and in our center, we can get the bronchoscopy the next morning, rather than doing it on Friday, calling the pulmonologist, and they say, sure, we'll put it on the schedule for Monday. So, but even in our data, we found that by starting the therapy within the if you do the bronchoscopy within 72 hours, it does not seem to impact the ability to get a positive Galactomannan from the BAL sample. So a number of studies indicate that outcomes are likely better when you start the therapy for the right diagnosis and start it promptly. The halo sign is a radiographic feature of early Aspergillus. It occurs during the first week, and beyond 1 week, it goes away. And so when the data from a large randomized trial of voriconazole versus amphotericin was evaluated according to whether the Galactomannan was present when the therapy was initiated, you can see the response 20% higher when this was started early compared to later. And this was true no matter what you started, you did substantially better. Now, fortunately, in the past, this used to be a contraindication to taking a person to transplant. And when it occurred after transplant, it often was associated with a very high mortality. But fortunately, outcomes are dramatically better with decreased attributable mortalities, both in allogeneic transplant patients as well as adults with AML. And I think that there are several contributing reasons why the outcomes are improving. First is we all are using these CT scans more aggressively. We're detecting these earlier and starting the therapy early. We have the new biomarkers, which we've discussed, that allows earlier start of antifungal therapy, but also it's associated with the Will Rogers phenomenon. A number of cases that we suspected fungal infection, there was a nodular infiltrate, but we didn't do a bronchoscopy, we didn't do a Galactomannan. And so we empirically treated them, but never counted them as a true infection. And so we were probably treating milder cases with better outcomes. And so we just now are including more cases. I think that may be a contributor. We clearly have better drugs. We'll talk more about that. And we have more in new strategies, as Kieran has alluded to, of using these much earlier, either as prophylactic or preemptive approaches. So the first better drug that we had was voriconazole, and the IDSA guidelines indicate that is the preferred first-line therapy for aspergillosis, and that's based on this randomized trial with the data depicted here, where you can see the response rates were substantially better, and that resulted in a 12% improvement in survival rate. And that clearly became the centerpiece for the preferred first-line treatment. Now, some individuals cannot tolerate voriconazole, and thus alternative regimens or the lipid amphotericins. I would caution you there has never been a head-to-head trial of a lipid amphotericin with voriconazole, nor with a conventional amphotericin B in a way that is in a large, substantial trial. And thus, we don't really know if lipid amphotericins are as good as voriconazole or not, and it's been debated. But we do have some data that help us guide us with the dose of lipid amphotericin. Since it's less toxic, you can give higher doses than conventional amphotericin. And so one of the questions, well, if a little is good, more clearly must be better. We're oncologists, most of us. And so a randomized comparative trial was done looking at a more standard dose of 3 milligrams per kilogram per day with 10 milligrams per kilogram. And interestingly enough, the response rates were not better. And there was actually a numerical reduction in survival at 12 weeks with the higher dose, but this was not significantly different. But more importantly was the toxicity was higher rates of nephrotoxicity, and there was financial toxicity with the higher doses as well. Well, what about combination chemotherapy for fungal diseases? We're oncologists, hematologists. We feel very comfortable with the concepts of combination therapy. Well, for fungal infections, there were both preclinical in vitro data, preclinical animal model data that suggested that different drugs from different classes actually had either additive or synergistic effects. There were some human retrospective data that suggested there was a benefit to using a combination compared with monotherapy. But recently, there were no prospective large-scale randomized trials until this was done by Karen. And as you can see here, the combination of voriconazole with a nidulafungin, so two classes, an azole and a kind of candid, different mechanisms of action, and that was compared to voriconazole alone. And as you can see, the mortality, which was the primary endpoint, was lower in the combination therapy, but this was not statistically significantly different. The difference was 27.5 versus 19.3%, and the p-value was less than 0.10, but greater than 0.5. In a post-hoc analysis where we looked at the patients who had Galactomannan positive cases, these are cases that we think have a lower fungal burden, and if there is a true benefit, we are more likely to discern it in that cohort. And as you can see here, that the curves diverged even greater, and this p-value was less than 0.05. But I would caution you, this was a post-hoc analysis. Now, there are two new drugs. Karen has alluded to posaconazole. There's a new IV and delayed-release tablet formulations. These are approved for prevention in the United States, not for treatment. And Karen has alluded to the delayed-release tablets. I would make one cautionary note to all of you is that the dose is different than that of the oral solution. The oral solution that many of us have used over the years was given 200 milligrams 3 times a day, but the new formulations are given 300 milligrams twice on the first day as a loading dose, and then once daily at a dose of 300 milligrams thereafter. Markedly improved bioavailability, although the package insert says it should be done in a fed state. In fact, studies show that the bioavailability is very good in fasting. The old adage that if you're not eating, you're not absorbing the oral suspension of posaconazole, that no longer is true with the extended, the delayed release tablet. And isavuconazole, which is now licensed in the United States, both is oral capsules and IV formulations, and this is indicated for the treatment of Aspergillosis and the treatment of mucormycosis. This is a broad-spectrum azole, as the other broad-spectrum azoles, a broad spectrum of activity against a variety of pathogens. Importantly, this is active against both Aspergillus and mucor, which are the principal ones that we deal with. It has the same mechanism of action as other triazoles, so cross-resistance could be a concern. We need more data. It's rapidly absorbed, 98% bioavailability. It too, like the newer formulations of posaconazole, has no pH or food effect. It is metabolized by cytochrome P450, the 3A4 isoenzyme. Less than 1% is excreted by the kidneys. There is no dose adjustment needed in elderly, liver-impaired, or renally impaired patients. And the dose is proportional increases in exposure. The safety is very similar to that with voriconazole, but actually some fewer drug-related adverse events, particularly with skin, eye, and hepatobiliary effects as well. The large randomized trial in Aspergillus is depicted here. The all-cause mortality through day 42 was 19% in isavuconazole, 20% in voriconazole, not significantly different. A key secondary endpoint of overall success was 35% and 36% respectively. And importantly, there were fewer drug-related adverse events with isavuconazole. In an open label study in which patients with Aspergillus plus pre-existing renal impairment to get more information about that, or patients with other invasive fungal infections, and the principal one was mucormycosis. You can see that as first-line therapy, there were responses seen in 32%, and as salvage therapy, 36%. So very respectable response rates. I would point out that the drug comes as a prodrug, isavuconazonium. The dose is 372 of the prodrug, which is equivalent to 200 milligrams of isavuconazole. And that's given either orally or intravenously at 8-hour intervals for 6 doses, namely 3 times a day for 2 days, and then once daily thereafter, either orally or intravenously. So in conclusion, CT scans, the pattern and the timing after transplant influence the differential diagnosis and can be very useful for you. The fungal biomarkers are very helpful, not only in screening, but also in the early diagnosis of invasive fungal infections. The molecular testing, for those of you outside of the United States, is very promising. And the addition of biomarkers to the BAL adds greater diagnostic accuracy and avoids the need to do biopsy procedures in most patients. Molds cause at least half of nodular infiltrates, and of the molds, Aspergillus accounts for most, and early therapy matters. Thank you very much.
One of the questions is with regards to activity against specific Rhizopus species.
Okay, would you like to
there's
speak to
Rhizopus
that?
oryzae is very difficult, frequently has a higher MICs to many azoles. And that's certainly true for posaconazole. I'm not sure that we've studied that as intensively with isavuconazole, but
There is some variability.
there's some
yeah.
variability there with that species.
Okay, any other questions
And
from
then would you consider really devising any kind of prophylaxis strategy to target mucor infections? Would that ever come into play? Is there any kind of critical threshold incidence or anything else?
So there was a considerable concern with the growing use of voriconazole, which has no activity against mucor. With the wider use of that as prophylaxis, there may be emerging and several increased breakthrough infections with mucor. Several centers reported that. Actually, the large prospective randomized trials did not bear out that there was an increased frequency with the use of voriconazole. And moreover, the Transnet data, which was sponsored by the CDC, 23 US centers, 4 to 5 year prospective survey, showed that mucor is relatively infrequent in most of our centers. But I would point out the devils are in the detail. There was a tenfold difference in the ascertainment of mucor in those centers. And of course, a lot of this is biased by the aggressiveness that a center might have in diagnosing these pulmonary infiltrates. And there, I'm aware of 1 or 2 centers that have had a higher than expected incidence of mucor. So there may be individual situations where I think that might be, but I think for most centers, probably not, in my opinion. What about you?
No, I agree. It's a very, very low prevalence still. And I think that's what we're kind of picking the low-hanging apples off the tree with these prophylaxis strategies. And the thing and it addresses one other question in here, for instance, why don't we use itraconazole? Because it's always a risk-benefit. We're not only just targeting what we want to prevent, but we really need to consider the toxicities and the tolerability when we're giving it to 100% of people. Frequently, the outcomes are really driven by those toxicities that can override the specific antifungal benefits. And that is, for instance, why we don't use itraconazole very well. Not very well absorbed, and some hepatotoxicities of concern.
So returning to the first question, which of the following do you now plan to use most frequently to prevent invasive fungal infections in patients undergoing transplant? Option 1, again, is either a hybrid approach of fluconazole or mold active, depending on the risk, or biomarkers. Option 2, posaconazole in everyone, voriconazole in everyone for option 3. Option 4, micafungin. Option 5, liposomal amphotericin. Okay, it looks like most of you are sticking with your decision. Karen, would you like to comment about that in your center?
Yeah, that's exactly what we do. I think it's a really good, safe strategy that if you can employ, especially the biomarker-based screening approach and close clinical follow-up, actually it works pretty good.
Yeah, I would point out one additional facet about the 0101 trial, the BMT-CTN trial that I chaired, that we did a multivariate analysis of risk factors in older age, graft versus host disease, and being transplanted for AML were independent risk factors for the development. And then we looked at whether VORI had a benefit in each one of these risk factors, and there was a significant benefit to voriconazole in the patients who were transplanted for AML with improved fungal-free survival, significantly reduced rates of fungal infection. That was a post hoc analysis, but we will never do another study, so we've actually incorporated into our practice at our center. All right, the second question. How often do you plan to use non-invasive tests alone or in combination to screen for invasive aspergillosis in high-risk hematology populations? Karen, what would you think?
You know, I think it's very, very clear that if someone has any kind of syndrome that is potentially associated with aspergillosis, then checking the serum galactomannan and absolutely doing a bronchoscopy with galactomannan and fluid is actually a very good idea. We haven't, the problem is the difficulties in doing, for instance, twice weekly screening for serum galactomannans and the feasibility of doing that over a long period of time. Some centers are better adjusted to be able to do that, and a lot of centers in Belgium, especially in Europe, have been able to show quite good success in doing that. And I think that that is something that we need to look forward to potentially with some of the new assays coming in, maybe the beta-glucan assay, who knows, but I think that having a high suspicion with early screening and using those biomarker-based tests that are available in your institution are a very, very good idea.
Thank you. Which of the following combinations do you now think would be most likely to have a positive effect on survival at 6 weeks? Amphotericin plus inidulafungin, amphotericin plus itraconazole, VORI plus inidulafungin, fluconazole plus itraconazole. All right. Karen, would you like to make a comment?
Sure. You know, that the randomized trial, kind of just like the 101 prophylaxis trial, I don't think that's going to be done again. That was a post hoc analysis that showed a significantly different, in fact, a 35% improvement in survival in the people who had diagnosed disease based on positive galactomannan in either blood and or BAL. That was post hoc, and it was done not because we were picking through weeds, but because it was 80% of the patients who were enrolled. And I think that is, and we didn't suspect that to begin with. I think it's a really informative finding, and that coupled with the 0.08 very large trend to better survival suggests that at least with voriconazole primary therapy, adding an echinocandin when it's feasible is probably a good idea, and that's what I do. I don't keep people in the hospital to get that IV drug for 2 weeks. You know, there's a lot of these details that come out, because I don't know that it's, we've shown that that's a good use of resources or clinical confirmation, but in people who are sick, I think that probably the 2 drugs is a better way to go.
Yeah, you know, there's less data about other combinations, but certainly a polyene, amphotericin, and a echinocandin would also be a favorable thing. And but using 2 azoles probably not much advantage, and likely an azole plus a polyene less favorable because of the various mechanisms of action. But clearly either a polyene or an azole with an echinocandin, I think it's a very attractive, and the strongest case clearly is with VORI and inidulafungin. So our last question is, which of the following do you now think would be the most appropriate option for the initial treatment of disseminated mucor? POSA, VORI, isavuconazole, and echinocandin, lipid formulation of amphotericin. Okay, the majority have voted for lipid formulations, and isavuconazole and posaconazole were somewhat less. Karen, do you have a comment of that, or shall I speak to that?
No, and I think speaking to that will address some of the questions. So if you speak to that,
Okay.
I can ask you another question.
In my opinion, our strongest record is the lipid formulations of amphotericin. We still do not know superiority of one versus the other, no controlled trials. I doubt that there ever will be, to be perfectly honest, because it's an infrequent disease. It would be hard to mount such a trial. But I think the three choices that all of you have selected are very good choices. In our practice, we start with the lipid amphotericin, and then we step down to either the newer formulation of posaconazole or isavuconazole. I think all three are good options, and there might be toxicity considerations that would lend you to choose an azole over a polyene, particularly if you have somebody with nephrotoxicity or fluid imbalance, that would be an azole might be better. Well, thank you, all of you. But I would remind you that you can download these slides at this website that'll remain there. And thank you all. Have a good day.
This activity has been jointly provided by the Medical College of Wisconsin and PVI, Peerview Institute for Medical Education. Thank you for listening to this activity. To view the rest of the CME activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/GKU. This activity is supported by educational grants from Astellas and Merck & Company Incorporated.